There we go. I was going to say good afternoon, everyone, but it's actually still morning. Good morning. The time is actually flying by for me today. So welcome to our November WPCC meeting. I'm pretty excited. We have some great presentations coming up, and I'm looking forward to hearing from them. So let's go ahead and get started. Go ahead and Slack. Go ahead and chat in your name, organization, and title. I think I know most of you, but there are a few new people that have joined us. One for sure, but we'll meet Jason whenever he presents for Family Health Centers. So go ahead and Slack that in, chat that in. Give you a couple minutes. Welcome Heather and Jackie, Caitlin, Loretta, Misty, Nathan, Nicole, Becky, Stephen, Ton, and Whitney, Shania, David, Deb, Haley. All right, so let's look at what we got going on for the agenda today. We have a few announcements that we'll go through, and then Catholic Charities is going to give us a presentation on their integration of the PHQ-9. And then Family Health Centers will talk about their hypertension care quality improvement program that they've got on. And then we'll have an open dialogue on ACH priorities, what we've presented to the board. It says estimated budget. I actually took that out. I didn't figure we needed to go through that. I actually stole John's slides from his TCDI meeting. So if you guys go to that, you'll see some duplication. Sorry, I didn't steal, I borrowed. I repurposed. How's that? Sounds better. But we'll have some be prepared to type in and be prepared to come off mute, because we're going to throw in some fun in there. I do have some questions as we are planning for the next year. I'm just looking for some more guidance, because I want to make sure that we are planning according to what is valuable for you guys. And I've said that many times, but I have some more pointed specific questions I'll ask you. So I'll have you take yourselves off mute, or I'll have you chat in. So be prepared for that. Yes, John, we borrow from each other all the time. We repurpose it so that we have the same message. Isn't that the way it goes? Here's our minutes from last week. There's all the announcements that went out. Is Deb Miller on the call today? I think I saw her. Yes, I did. Hey, Deb, you were going to send me a flyer.
I was, huh?
Yeah, according to our on the Spanish diabetes workshop. Sorry, I just saw the minutes as I was reviewing them within the last week and did not reach back out to you.
That's great. And Caitlin's on the phone, and I do know that we extended the start date so we can get an updated flyer to you. Thanks.
You're welcome. You send that to me. I'll make sure I send it out to everyone.
Thank you.
And we heard from Shania and Shoshana and Joseph. If you're interested in those presentations, they were all really good. You can find them at on our website at ncach.org/WPCC. If you scroll down, you'll see 2021 meetings, and that's where all the, when I get them uploaded, the meeting documents from the previous meetings, as well as the recordings. I try to get those YouTubes. I get it uploaded to YouTube, usually on Mondays, right after the meeting or after our governing board meeting, and then getting assistance to get that uploaded to our website, and that sometimes takes a few days. Okay. If you see any changes or additions that need to be, just let me know. I have, I'm no longer approving because it's so hard on digital that if you need a change, let me know and I'll make the change. How's that? Just leave it there. All right, let's go with announcements. Monthly reports are due in November 3rd. It's for the narrative is what's happened in October. And then you have your dates for your metric reporting. Those are uploaded in the portal. If you're going to be late, please let me know. You need to get those in to get credit for payment. We've said that in, and it's only that 1 month cycle. So now that we're in the November cycle, if you haven't submitted for October, I would say either get that in today or you'll lose that 1/3 of that payment. So there are a few of you that I have not received your monthly reports. And so just want to make sure that you're aware of that. We do have the population health plan on the 9th, which is next Tuesday. I sent out an email regarding some population health land awards. If you are in the land, whether you're doing the homework or if you're just dropping in and listening, but not necessarily doing the homework, you're included in that. There's the link. It's one vote per organization. So please get with your organization internally and submit a vote for a peer award. And you'll see that all in the SurveyMonkey link, what those awards are. So you'll take care of that. That would be great. We'd like to have it done by this Friday, November 5th. We have our QI Affinity group on November 24th. It is the day before Thanksgiving. It's going to be open discussion. Tina Clark will be leading that or facilitating that. So if you have anything that you guys are working on or any questions you may have, feel free to bring them. If there's something specific you want to hear about or learn more about, or would like Tina to prepare something, just let me know and we'll get that information to Tina and she'll see what she can do for that meeting. And finally, we are going to do some WPCC evaluation. We've done one-on-one visits. We didn't meetings. We didn't do them in 2021. We usually do them in the summer, and we didn't this year. We've decided we're going to go ahead and do them with the wrap of the population health plan and the way the collaborative is changing. We thought it would be a good opportunity in December to January to do those visits, kind of wrapping up the collaborative and all the work that we've been working on. So look out for that email within the next few weeks to get something on the books scheduled December. I'll stay away from the holiday week, so to speak. So you're like looking mid-second, third week, mid-December, and then starting like the 10th of January. If you haven't heard, we have changed offices. The red star down here is where we are currently located, where we were currently located. For those of you who don't know Wenatchee, this is the main road coming in and then the bridge you come off. Hobby Lobby is right there. It's a very important place, or Fred Meyer. And we are now up here at Eastmont and 9th. That is our new location. It's the daylight basement of a dental and orthodontic office that are upstairs. So we are very excited to get moved. We have a few desks in there. Linda's in there right now. It is stark walls, so there's nothing on the walls, and there is no furniture except for the couple old desks that we brought over. We'll be getting furniture in the next week, and so hopefully getting boxes undone and putting the office together. We are planning something probably in January, an open house or something, so that you can come check out where we're at. And that is our new address, the 801 Eastmont Avenue, Suite C. And we'll send this out more formally, but just wanted you to be aware. Also, if you haven't heard, Senator Parlett is retiring December 31st. We've talked about it informally, but we haven't mentioned it formally yet, and it'll be going out. And I figured I would go ahead and give you that heads up just in case you haven't heard. We appreciate all she's done, and we're definitely going to miss her. And John will be our acting ED, and he has some big shoes to fill there. But he's been working on it and all the new changes that have been occurring, so he'll do great. And then I want to introduce David Gaynor. He's our new communications manager. He's on the call today with us. So David, can I turn it over to you and just tell everyone a little bit about yourself and your new role?
Sure. David Gaynor. I'm a native of Dryden. I grew up on an apple and pear orchard there, which I have the good fortune to happen to visit yesterday. We no longer own the property, but I always make an effort to get there a few times a year and just see what the place looks like. And in this case, steal a few angel trees that didn't get through harvest that are still on the trees to take back here to Yakima. I've been the public information officer at the Educational Service District in Yakima for South Central Washington for about 15 years. And for a few years, I've been wanting to do something else with my experiences in public relations, advertising, design, communications, graphic arts. And one of the places I've been looking at is back to my home territory. And I'll be, as of about 2.5 weeks ago, I started the position with communications manager with NCACH. Currently, while Linda is in the office, I am still in my house in Yakima. So I will be there in person at some point in the next couple of months on a more regular basis, and looking forward to assisting with the communication needs and outreach of this group and what I can do as appropriate to assist those of you as well on some of your outreach needs too.
Great, thanks, David. And again, welcome. We're excited. If you remember, Sahara Suval was our communications manager prior to David. She was only about a 0.2, 0.3. She had other responsibilities, and now David's taken on a full FTE. So we're excited about the work that he will be doing. All right. Any partner updates from managed care, community-based organization, clinical partners? Anything any of you would like to share? Major changes, staff changes, any programs or anything you're offering to the community you want others to be aware of? Okay, that uncomfortable silence. Go ahead.
Good morning, this is Connie Mumching with Community Health Plan of Washington. I just wanted to let folks know, just in case you have not noticed, that we do have 2 people that are serving as our interim regional manager for North Central, Liz Perez and also Joelle Chevy. So they've been helping out in terms of participating in facilitating regional meetings for us. So I'm in the process of recruiting for a regional manager for North Central. When that is successful, I will let you know, but we have folks that are covering that responsibility, yes, including myself as well, helping out.
Great, thanks, Connie. And if we don't have their contact information, can you send that over?
Sure, yes.
Thank you. Deb, you have an update?
Sure, I was slow to raise my hand this morning. It's Monday. Just a reminder for everyone, it is Medicare open enrollment, October 15th through December 7th. And Wendy, I already sent you that flyer to send out to everybody. I just sent it. Just as a reminder, we are free and unbiased. We are not brokers. So you can send any of your patients, I guess I would say, on this call to, they can call us, and the number's in the flyer, and we provide unbiased support, helping them understand all of the options that are available to them for Medicare. And then we can also help some low-income folks sign up for low-income support and other Medicaid specific programs. So give us a call. Thanks.
Thank you, Deb. Anyone else?
This is Misty with Melina. Sorry if I missed when managed care was going. I have a contractor in my house today, so my life is a little upside down. Really no updates. North Central, our team in North Central is really going strong. Haven't seen the problems we're experiencing with our Spokane team. Our Spokane team is really struggling recruiting, but in North Central, we only have 1 open position. So that's really good. Other than that, I really don't have anything. We're just, wrapping up the end of the year and looking forward to moving into 2022 strong.
Great, thank you, Misty. Anyone else? It's that uncomfortable silence, but it's also the struggle of trying to find your mute button. And I wanted to make sure that everyone has that opportunity and I don't mull over, because I know that when someone starts talking, you're like, never mind. I'll just not say that this time. So been on that end. So, all right, let's keep moving. And with that, I'm going to turn it over to Jason. And remind me, you have someone else presenting with you.
Yeah, it's Michelle Ferber.
Good morning, Michelle. Can I get you both to introduce yourselves, and then I'll hand it over to you for your presentation.
Sure. And real quick, Wendy, I guess what is the best way, because you're running our slides for us to switch to the next slide?
I can give you control of my computer and you can run them, or I can run them for you, either way.
We would like to run them.
Okay,
Thank you.
I'm giving it to Jason. You're signed in under Jason, so you should be able to control.
Okay, so good morning. I'm Michelle Ferber. I'm a clinical supervisor for the children's outpatient team at Catholic Charities, and I've been here for about 4.5 years.
My name is Jason Guest. I'm a clinical supervisor for the adult team. I've been here since for about 8 years. So
Today we're going to present on how we integrated the use of the PHQ-9. Bear with us for a few minutes while we figure out how to use the technology. Okay, so a little bit of history. We are, as an agency, we've been using the PHQ-9 in services for quite a long time. We've been giving it an intake to clients age 13 and older, and it's been used as sort of a regular assessment tool with clients as well. So I kind of want to skip into the next one because our slides kind of run together, sorry. So our goal was to have 100% of our patients that had a positive depression screen have a documented follow-up plan. So when we've used the PHQ-9 before, we were considering anything as a clinical score, right? I think it's 11 and 12, yeah, 10 and above. We're focusing on that. And when we implemented it into the whole person care, we did anyone with a score of 4 or greater. So that was the difference. And then the document, to be followed up, clients were to have a follow-up appointment within 30 days. One other thing that was different was we used it with ages 12 and older instead of 13 and older, as we had been doing. And so we had to modify our documentation a little bit on that. We had to add a way to track that clients had the follow-up plan within 30 days. And then we also had to change how we were administering those at intake and ongoing. So our use of the screening was pretty consistent across the board. It did dip when we had when telehealth started, when we started working from home. But for the most part, we were pretty consistent around between that 75 and 80 mark. So some of the challenges in meeting that 100% were that initially we weren't giving the screenings to certain clients because we were only giving them at 13 and older. So we had to retrain staff. Telehealth services, we didn't have all of those assessments available electronically. So when we were doing intakes via the telephone, we had to administer those verbally, question by question. So intakes took considerably longer. So if depression wasn't necessarily a target when the clinician was completing the intake, they were thinking more trauma or more anxiety. The PHQ-9 wasn't given consistently. We also had clients who just weren't able to complete the assessment tools either verbally, electronically, or even in person due to either not understanding them or mental health diagnoses, having, hallucinations or delusions. There are some clients that just can't complete. So we couldn't quite make that 100% mark. Some of our successes in that was that our workflows were pretty easy to modify. And we were able to, once we identified some of our challenges, act on those and make changes pretty quickly. And that also we were pretty consistent across time and during times of change. Like even when we went to working from home, our numbers were still pretty stable.
So for the second part of the project, so it was kind of a two-part monitoring, so administering the PHQ-9 and then following up with a monitoring of the depression screener. So for that section of, or that part of the project, our goal was to follow up in a timely manner with 75% of the patients who had a clinically significant depression screener initially. So at intake, if they score a 4 above, was staff following up with that at a 6-month mark or at a 3-month mark. So some of the things that we kind of ran into is that we didn't really have a formal process to track symptoms across departments. Some departments were doing it very consistently, and some departments weren't. As Michelle kind of mentioned, we were doing it for ages 12 and above, but not, or 13 and above, but not for the 12-year-olds. And it also kind of varied at the reassessment time, whether or not we were administering the PHQ-9. So there were some inconsistencies among staff on whether the PHQ-9 was re-administered. For example, if a patient wasn't maybe clinically significant for depression and we were treating them for anxiety, we might not administer the PHQ-9 again. And so some of those processes were not in place. So for this, our data kind of, it definitely was a little bit, I mean, it dipped lower than the initial data of just administering the PHQ-9 at intake. So in December of 2020, through here, we developed an auditing tool that was going to, try to help, because we didn't have a way to audit staff or the way the PHQ-9 was re-administered. So we developed a tool that would track and the follow-up of the PHQ-9. And then in April of 2021, our staff returned to the office. And so that helped with some of the numbers. And then in the summer, there was a kind of a big push with having these team meetings around the data for these projects and getting the staff in the room and really kind of looking at the barriers to collecting the data and improving the numbers. So as we can see, like as we at each step, the numbers kind of improved as we made changes. So some of the challenges and successes of this part of the project, the pandemic posed a lot of different challenges for us. So the recording of the PHQ-9 was definitely difficult during the pandemic. Staff might have been recording the paperwork, doing the PHQ-9 with the client, but there wasn't a real good way to get the data to the right person. There's difficulty engaging clients during the pandemic, and then telehealth services disrupted workflows. And then there also was staffing and training challenges. So monitoring staff adherence to the procedures that we had put in place, training new staff, and retraining current staff in the new workflow. So as we made changes, making sure that the current staff were keeping up with those changes. Some of the successes was being able to develop this auditing tool that really did help with improving the numbers, returning to the office, developing a formal process to track the depressive symptoms, and administering the PHQ-9 on a regular basis. We trained and retrained staff on motivational interviewing to improve client engagement. So where do we go from here? Kind of the road ahead is continue to utilize the PHQ-9 auditing tool, train new staff on the proper use of and tracking of the PHQ-9, and then continue to focus on the re-administration of the PHQ-9. So really kind of focusing on the stuff that we've implemented over the last year and continuing forward with that. And then continue to focus on ways to close the gap between the folks that are getting the PHQ-9 at intake and the ones that are getting it, a second time around to measure the difference, to measure the follow-up points. So. That's it.
Great. Hang on one second. I will. All right, there we go. Thank you, Jason, Michelle. I know it's not easy jumping in and presenting to a group you've never attended, a meeting you've never attended, and a position like this where we've kind of all know each other in some respects, so it makes it a little easier. But you guys did a great job jumping in into this work and presenting on it. I'll open it up. Does anyone have any questions for them?
This is Tom from Family Health Centers. I am wondering if you can talk a little bit more about the auditing tool that you made for the PHQ-9.
So we use CareLogic as our electronic medical record, and we were able to have our IT people build a tracking system into that. So we were able to pull reports to actually show numbers. And I can't speak to how they did that. That's way above my.
It's magic.
It was able to kind of break it down as a whole agency, and then kind of on a micro level with each individual clinician. So we were able to say or identify folks that were maybe needed more additional attention or needed additional support with the data entry or even administering the PHQ-9. So what staff were maybe not doing it or having difficulties, and then also kind of track it as a whole agency.
Yeah, so we were able to pull agency numbers and then individual clinician numbers. So say, Michelle, your numbers were 12% this month, right? Where are your barriers? We're going to talk to you and where are your barriers, and let's make a goal to get that number up higher.
And I guess the follow-up question is, when you're administering the PHQ-9s, are you doing this verbally? Are you doing this on paper? When does it get entered in your workflow into your EHR?
So a little bit of everything. When we were all working from home, we were giving them electronically or over the phone. In person, we tend to give the paper copies. And then we have a person, Rosa, who enters all of the data into the system. And so some of the challenges were that people were scanning them in and sending them to the wrong person or holding on to them because they didn't realize they still had to be turned on. I mean, at first we thought we were only going to be out for 2 weeks. So people were holding on to their papers for quite a while until we said, okay, well, we're obviously not going back anytime soon. So let's figure this out.
And then I guess another question I have is, you mentioned briefly in there about motivational interviewing, training and retraining staff. What resources did you use for this and how was it received by staff?
So Heath was trained he was a motivational interviewing trainer. And he broke things down. And I think some of the resources we got from this group, I'm trying to remember that there were like smaller individual, and that was before I joined the group, so I'm not quite sure, but I remember Heath providing things, and during team meetings, we would go over like one or two of them. Because sometimes clients just don't want to do the PHQ-9, right?
Well,
So
I know a lot of feedback that the wording on it is awkward.
yeah,
And
it
it's
is.
awkward in Spanish as well. So
It's worse in Spanish, yes.
yeah, thank you. I'm curious because we're always doing ongoing work on this as well. So
Mhm.
Thank you. Anyone else? Deb, you have your hand up. Is that from earlier?
That's from earlier. Sorry, I'll lower it for
That's
you.
okay. Just wanted to make
There
sure
we
I
go.
wasn't missing something. Anyone else? I'm curious, going back to the motivational interviewing, because I know that Heath is no longer with you guys. Some of those pointers or that you guys reviewed over in your staff, have you held on to those? Because I don't believe you now have a trainer within your organization. Is that correct?
Yeah, we don't have a trainer in our organization. We still have all of those resources. And we definitely have held on to those. And we also, that's an ongoing thing. If we see a training, we send staff to them. So actually all of our adult case managers and one of our children's case managers attended a motivational interviewing. It was, I think, last Thursday through, no, it was just Thursday. I'm trying to remember the agency, but it was an online training.
Great. Thank you.
Mhm.
Anyone else? Any other questions? Okay. Thank you both again for presenting. Great job. Great process that you guys hung through it. Hung through it. Is that right? Doesn't even sound right. So through the ups and downs of COVID, as well as I know you guys have had some staffing issues, probably a little more than others, but still weathering that storm. And I appreciate you guys jumping in and doing a great job on this presentation. So thank you. Sarah will be proud. All right, let me turn my screen share back on. And Virginia, I saw that you popped on.
Hi, good morning.
Good morning. You want to introduce yourself? And do you want me to control, or would you like to control your slides?
I would like to control them if it works okay.
I'll give you one. Oops, I did not mean to stop screen share. 1 second. Screen to share and remote control. I'm giving it to you.
Okay, thank you. Hi, everyone. Sorry I can't attend the whole meeting. I've got another thing going on today. But my name is Virginia O'Kelly, and I am a registered dietitian. I'm also a certified diabetes educator. I'm currently not working in those positions. However, I'm working with family health centers and helping with projects there. So one of the recent projects I've been helping with is our hypertension care. And so Brendan and Ton have asked me to do the presentation on this. And I'm happy to answer questions as we go along. If you need to interrupt me, I'm fine with that. Otherwise, we'll do questions at the end, and Ton's going to pitch in on a little piece of it as well.
Virginia, I'm sorry to interrupt you, but for some reason I'm not able to do mute control on this page. Your mouse is, I don't have you.
That's fine. If you just want to go to the next slide, I'll just say next slide if we want to do it that way. So we got into this project through our quality improvement program, and we feel like there's a lot of problems that COVID has caused, but it's also created some opportunities, especially for smaller organizations like family health centers. We're a little more flexible and nimble in changing things. So we thought we were looking at our telehealth services and really excited about how we could continue to provide care without exposing our patients to coming into the clinic. However, we recognize that especially with hypertension, getting those measurements in order to evaluate our quality and also to treat our patients was missing. And some of the places like fire stations, emergency services, pharmacies, places where people tend to go other than the clinic to get their blood pressure monitored, were also not doing that. So go ahead and go to the next slide. So our clinical director and head of the QIP committee, Brendan Smith, Dr. Smith, developed a PDSA for home blood pressure monitoring. And about the same time, I became aware, I worked with Sarah E. Sarlicker at the Department of Health for many years. I don't want to say how many, but we worked together on several diabetes projects. And I heard that they were offering free blood pressure monitors. So I jumped on that. Unfortunately, the blood pressure monitors were surplus Army manual monitors that they didn't tell us about, and realized that we would not be able to use those for a lot of our patients. So Brendan was able to use another grant to get us started purchasing some monitors through our pharmacy. And then our community health worker, Lisa Lugo, offered to help train some of the patients, because we realized that a lot of these patients would not be able to measure their blood pressure without some assistance and coaching. And also a medical assistant in Tonascus. We had 2 sites where we had the opportunity to try to pull this all together. Go ahead, next slide. In the meantime, Sarah became interested in her department with the Washington State Department of Health, the HEART program, became interested in helping to create a project. So we basically created a grant. This is my first, well, maybe not first, but it's one of these opportunities that don't come along very often, where you get to create the grant specifically tailored to your facility. And that's what we were able to do. And then we met monthly with Sarah and her team and our team. And sent them a monthly report. And then that way we were able to bill some of our time, additional time and things for this grant. Go ahead and next slide, please. So we decided we needed to come up together with the Department of Health on what we would report to them in terms of data, and our EHR. Trying to set something up on our EHR was really not possible, especially on short term. So I came up with a spreadsheet, and we agreed that we would track this kind of information: the trainer, who referred the patient, that we did their training, and you'll see the things that are in blue underlined. Those are links to the training modules, so they could just go to this site, track what they were doing, click on the modules, and print those out for the patient. That was the idea. and also to try to complete an action plan with the patient, because my training with self-management is that the patient needs to agree whether they're going to test once a week, twice a week, daily, twice daily, because everyone has a different idea of what they would like to have, but what the patient's willing to do, I think, was really important. So that was part of that project as well, was some self-management, and then tracking initial blood pressures, some interim blood pressures, what they brought to us on paper, because we don't have the Bluetooth ability with these monitors. And then getting some data at the end. Also, kind of halfway through, Sarah Eve wanted us to add smoking cessation just as an optional thing. We did do that with some patients. And then just some notations that we keep, especially for success stories. So go ahead into the next slide. So part of the grant was that we would report monthly. So I think Ton maybe gave me something similar, this template. It works beautifully. It's just a template that we use in Google, and we just keep adding to it each month, and then print out a PDF so that we can submit a monthly report. But the report kind of adds to, so you see the whole story on those reports. Go ahead into the next slide, please. And some of the steps we took was, we had to find the monitors because we realized that, especially our Medicaid patients, it was not a normal coverage for them, and trying to get pre-approval to get one was a lot of work. So through this QI grant, and then so thankful for Community Foundation North Central Washington, they gave us an additional grant to purchase monitors. The Department of Health told us they absolutely would not pay for any hardware, only for staff time. So that kind of became a barrier initially. We used modules created by the American Heart Association to do the lifestyle coaching, and then we used just a health action plan through our health home program. And the community health workers have training in that as well. So that's how we did with the training of the trainers. And then the rest is just what we have on that spreadsheet. So go ahead to the next slide. Just some sample tools. We have American Heart Association tools to train the trainers so they understand how to do the measurement themselves. And then go to the next slide, please. Is a tool that we use for the patient to make sure that they do it properly at home as well. What we found was that people were being told by providers sometimes to measure at home or get a monitor, but they didn't necessarily have any guidance as to what a good monitor would be. Some were using wrist monitors inappropriately, and then people were not real good at just following the instructions out of the box, and so they'd get frustrated and not do it. So we found that having this training session with the patient to have them show us was super important, and not everybody is willing or able to do it. Next slide, please. So part of this QI, of course, the driving factor was our population health reporting, but we needed to separate out the information. So the purpose was to improve all of our population health, but the project was taking a smaller cohort. So we had to kind of separate those out. But we did use this registry health program that I'm not sure, whether we will continue it or not. That's Brendan can address that maybe at a later time. But we're able to pull reports from that. So I will show you some graphs from that. Next slide, please. But the PDSA in action, getting started, we had to put it on hold because of COVID surges, but we're starting back up. We've currently got 61 patients enrolled. About 30% are finishing the entire program. Some drop out, some we have not been able to get in contact with we're running about 30%. And this is just with two of our sites. But, you know, the highlight has been the anecdotal stories from patients that have lost weight, stopped smoking, you know, doing better, and they just feel like that individual intention, and maybe the biofeedback from the blood pressure monitor itself has been helpful in making helping them make changes in their life. So we feel like this is the team-based care, because adding community health workers and people that can do some of the coaching that our medical providers don't have the time for is the way to really get to these improvements that we need to in our population. Next slide, please. So in the provider visit, so what I did is I tracked I do a lot of spreadsheets when I do projects. So I have a separate spreadsheet and monitoring the numbers that we have. And these are just graphs. Some people like graphs, some people don't. But this is basically each point there is the patient, separate patients that are enrolled in the program, their readings in their office at the provider visit, and this is with the cuff that's used in the clinic, not the home monitor cuff, and then 4 months later in the clinic with a clinic cuff. So this is not the results from the home monitoring necessarily, but these are the people that are doing the home monitoring and how it's affected their results in clinic. Next slide, please. And these are the home results for the people that have brought in their home results. What we did is put them again on a spreadsheet, average them out for 2 weeks, whatever they were able to take and bring in, and then look at those numbers and see. So this is what the patient is seeing. Was, you know, for their readings before and after. So their initial reading on their home monitor when they came in, and then their readings after at the 3 to 4 month period. Next slide, please. So then this is the systemic, this is the population health that we look at. And you know, we're not a research center, but we can't say for sure. I see Todd smiling. We feel like our research center sometimes. But the red arrows are basically pointing to the clinic sites where we did this project. And we know we didn't get enough numbers of patients necessarily reduced to make this blip. So we feel like maybe just that highlighting, spotlighting, extra resources towards hypertension is maybe affecting other patients as well. So this is hopeful information, not necessarily research, but we feel like this is what we'd like to see at all our sites when we get done with our project in September 2022. Next slide, please. So things we've learned, of course, you always learn things, and I want to pass these along if anyone else is doing them, is, start with a small focus group and then expand. And then as soon as you start expanding, you start seeing problems. Am I okay on time here? Okay. So, it does require participation on the patient level. Not all patients are going to or willing to. They might say they do and then they don't. Some patients aren't ready for self-managing, making those healthy lifestyle changes. And then, what is success? Do we look at the population health as success? Do we look at the percentage of patients that complete the project as success? So those are things we haven't really figured out yet completely. And then Tan's going to talk a little bit about our population health and how we're working on team-based care to expand that. And then a really important lesson I learned in doing the training for other medical assistants is that the medical assistants, even though they know how to take a blood pressure in the clinic with the equipment that's in the clinic, they do not have experience with using home monitors and actually teaching other people. They tend to just want to do it. And so teaching someone how to do it and knowing how to do a blood pressure, very different. And we're rearranging our curriculum to accommodate that lesson learned. Next slide, please. So what we found interesting too is we did sign some people up that were frustrated because they had a wrist cuff or another monitor at home, and they said, I'm getting all these weird, readings and I don't like it, so I'm not taking my blood pressure anymore. And what we found is just they didn't have good monitors, and they didn't have good information on how to take their blood pressure at home. So we've had some happy customers with having that additional layer. We found some patients that had what's called white coat syndrome. Nobody wears white coats in clinics anymore, but once upon a time they did, and they call it white coat syndrome because when people saw that doctor come in or nurse come in with a white coat or hat or whatever on, they immediately, their blood pressure went up. They got nervous, right? So their blood pressure was only elevated in the clinic, but not when they got home. So we're able to see that, and patients are feeling much better knowing that occurs. And one of the ways we found that with our CHW that had trained on mindfulness and mindful breathing was she was able to just take a patient for 5 minutes and help them with some calming exercises and take their blood pressure afterwards, and see a big difference. So so that is those are the lessons that we've learned. Next slide, please. So I just did a little research the other day because just to see, why these projects, it seems like it makes sense. Like just have people do their blood pressure at home, and that would be the best way for people to manage this. But what we found is that that a lot of providers are not comfortable with this, and the reasons for that are interesting. They don't like them because not everybody adheres. They do the training, they set them up, get it done, and then not everybody does it. And so that they don't feel like that's successful. Sometimes they feel like patients are getting more anxious and more anxiety from doing their blood pressures at home, and they don't want to put that burden on them. They'd rather just have them come in and do it periodically. There's also the problem of when they bring their records in, they want someone to look at them, and they don't always have someone in the clinic have time to do that. So just so you know, these are like clinical research, American Heart Association clinical research reasons, and they do occur, and even in our system as well. Next slide, please. So it does take a team for this kind of work. The patients and the providers that are doing this work have recognized that the effective reduction of high blood pressure is a team effort, and self-measured blood pressure monitoring provides this link between the limited amount of care and measurements we can do in the clinic and where the real work occurs, which is with the patient in their home all the time. And this is true for people with diabetes and any other chronic disease as well. And I just have the link to the American Heart Association journal with that, if you want to refer to that. Next slide, please. Ton, I'm going to let you take over for these next 2 slides, and then we'll do questions.
Okay, so when Jenny's been talking about this team-based care, Family Health Centers is going all in on this idea. If we're really truly going to move to value-based contracts, if we are really looking at population health and overall health, this team-based care seems to be a critical component of providing that to our community. So in fall of 2020, we had a centralized call center, and then each clinic had a patient registration, a patient navigator, and then a registered MAR, that's through the Department of Health registration. And then we have our own MAC apprentice program where we get a lot of our MACs. Also, we hire MACs from like graduates of Wenatchee Valley or other programs. So that's what our teams look like that we're supporting providers in the center. But what we found, and we did some focus groups, we talked to different we talked to different, each of these different positions, is that each person was limited in their scope of what they could do. It felt overwhelming. And they also didn't feel like they could step into where it really needed help. For example, our patient navigators did a lot of paperwork, but couldn't jump into the patient flow because they didn't have the skills to room a patient. And then we also, after talking to different people, we found out that we didn't have a centralized medical record. So each clinic was doing several different types of medical record work, which we weren't accounting for in any job descriptions. For example, insurance would send off for an audit, send it directly to that clinic. That clinic would have to collect all the information, send it back. Sometimes we're talking about like a box full of papers being sent back. And so we looked at, we have EHR, we need to make this EHR work for us instead of us working for it. And what are we going to do? So we took, in the kind of next slide, please. We are in the absolute storming phase of change management right now. But what we're looking at is we took our call center, which is centralized, and our patient registration, which is at each of our clinics. We have 6 clinics, cross-training them. So they each get, so they know how to cover for each other's positions, which there's similarities, but there's definitely differences of someone who's the voice of family health centers versus the face of family health centers. And then have a pay incentive for people who are cross-trained to do each other's jobs. That way we can be a little bit more fluid in moving people around from clinics to centers and transferring phone calls. We also took this patient navigator position, which was highly in the paperwork of looking at pre-authorizations and centralized medical records. And we took out a chunk about, we estimated about 30% of their job, and put a centralized medical records department together. And that started in August. And then as of today, we have a central navigator also running our OB programs, because OB has some different spreadsheets to handle. That's a centralized team that is taking on our medical records and taking on some of the centralized jobs of the patient charts that don't need to be done this day. So that leaves us in the clinics with what we're calling community health workers level 2. And these are people who are cross-trained. They're going to be trained as MARs, which is the attestation through the Department of Health, that they have certain skills, like they're competent on their vitals. They have some CLIA wave testing. There's some basic skills that we're testing that we have trained them to. And also they're taking the DOH community health worker course to become certified community health workers. So really looking at that, having that idea of patient, looking at patients from not just the medical perspective, but as a whole person care. And we're going to assign a community health worker level 2 to each provider, working with the certified MA and or the medical MAR, depending on how that team looks like at the center. And the focus for this position is, of course, to help with patient flow, because we're not an organization so large that we can be highly specialized, but we're also not so small that we can be one person does everything. So we're trying to find the right niche of where we're putting people. So these community health worker 2s in the clinics will really focus on that social determinant of health work, but also be able to work with patient flow and getting patients in rooms and doing some of the things that keep the patients in, getting rooms and getting to see the provider. As I mentioned, for the MA certified, we are actively recruiting our current staff to go into this program. We do pay for their work with a promise to stay with family health centers for 2 years. So this is what we're starting. Like I said, lots of change management going on. When I have the central navigator today, what we're going to do is list of what can be done for the patient today that we should do in the clinic and get it done, like straightforward prior authorizations, referrals to specialists, what can be done today, and then what needs to be centralized. I think all of us on this call know that like VA requests tend to take a lot of time and energy, and maybe we should centralize some of that work so someone has that expertise and knows who to call. So that's what we're looking at, and we have a lot of push and pull over the next couple of months of doing this, training all these people. We have now 13, starting next week, we'll have 13 people in this position, in this CHW2 position, which is a brand new position for us. And then the other part that we have done is we have $1 million grant for vaccine accessibility for COVID-19. We have hired a team of 5 community health workers. We're calling level 1s to differentiate them from the ones in the clinic. And we are taking our mobile unit for vaccines and going to the underserved zip codes in Okanagan County and offering vaccines. In this last month, we've been to Pateros twice, Oroville twice, and to Winthrop. And we're going to plan several more events and hoping to also take some of this, the booster shot, now that Moderna is going to be approved as well for boosters, taking some of that off the clinics to do at the mobile units, because we can do a lot of people in a day with our staff of 5 doing patient registration and all the paperwork that's associated with that. So lots of change management, lots of ideas zooming around. I think in a few more months, we'll know if this has been a good idea or not for doing this, but we have some excited staff. It's also the best part in my eyes is that we are offering our staff a career track. And we're giving them, if you can do this, we've got places for you to go, whether it's behavioral health, whether you're more of a medical records person, whether you're going to really want to work, be a part of our MAC program someday. We're giving staff those options because we need to grow our own. Okanagan County is isolated. We have a lot of people who, for a lot of reasons, whether they start families younger, whether they want to not move away from their families, we need to have our own programs that we can train and make sure we have well-trained staff by ourselves. So that, I think the next slide should be the question slide, if I'm remembering correctly. Yes.
I had to find my mute button. All right, thank you, Virginia and Ton. Does anyone have any questions? I'll say our brothers are trying to find their mute button. I, like Connie, who just posted in the chat, I'm very excited about that team-based care model. And I know you guys have been through a very long process of really determining what the right roles and responsibilities and rewriting job descriptions and that. So it's cool to see it finally come to fruition and you utilizing that in a way that's productive for family health centers. I'm excited about this blood pressure monitoring, the home base. I know that several clinics have talked about it, and remote patient monitoring is another one. It's a little bit different, but still that home-based monitoring and to see where it's going to go and how patients can become their own advocates and control of their own health. So kind of taking that self-control back versus being dependent on the clinic itself. So that's really cool and exciting to see.
Yeah, I think it feels a lot like a lot of years ago when we first started blood sugar monitoring, and there were a lot of people like, well, why would anyone want to test their blood sugar at home? You know, that's a lot of problem. You have to poke your finger. But what we realize is that people really, at least a portion of people, really do want to manage their own health, and they don't always have the tools or not given the tools to do so. So I think with blood pressure, it just seemed so backwards to not have people be doing that. And I think we'll find in the future it's more highly accepted. I know a lot of the EHRs do have programs. Athena has a program. The problem is you have to bill for all these services and monitors, and it's not always easy because some insurance companies pay for them and some don't. We ran into this with diabetes too. It's like, oh, we'll pay for a blood sugar monitor, but we'll only pay for this brand. And so it still is complicated in the diabetes field, but it should be pretty straightforward with blood pressure monitoring. And I think for something like this, where you can get a grant and purchase pretty good monitors for under $30, it's totally worthwhile at least attempting before you go full board into a Bluetooth kind of really expensive program.
Or is it something that's on loan checkout?
I'm sorry, say that again.
Do the patients keep their blood pressure monitors, or is it just on the loan or a checkout system?
they keep them. They are given the monitor. The whole cleaning a monitor and checking it when it comes back in for the loan program is not a good idea. I'm sorry, but it sounds great, but for under $30, you can pay someone $30 just to clean one of those things. And I did a loan program 20 years ago, and I remember the first one that came back, the guy was a smoker, and you couldn't get the smell out of that cuff. It smelled like smoke, and so we ended up giving it to him. So it's just we really need to push the insurance companies to provide us with this simple tool for people if they want it and they're willing to use it.
And I think that's part of this vision of value-based care, right? If this person needs an air conditioner to keep them from ending up in the hospital too much when it's 116 degrees, if this person needs a blood pressure to monitor at home, this is the essence of what we should be doing with those value-based contracts.
Yeah, air filters is another really great one during the summer with all the smoke. We worked really hard, and all the agencies worked hard to put together some kinds of, duct taped air filter system for people so they could survive. And when we ended up in Methow Valley, we got the Okanagan County, we got 2,000 air filters donated by a company for free, and they disappeared in 3 hours. So it was definitely a need, but people didn't feel like they could afford them.
Anyone else? Any questions, comments?
We can't hear you.
I don't know what's wrong with, can you hear me now? It's like if I start talking, then eventually.
Yes, I can hear. I think you were just too far away.
Yeah, John was still on the phone. Maybe he still is. He knows I need a new computer. My volume is not good. Is that a good reason to say, hey, I need a new computer? Can you tell your boss this? Okay, good. I'm sharing my screen in case you guys didn't see it. They put on this questions, if you're interested in support and potential grants for managing hypertension, there's some contact information. I'll leave that up for just a few minutes, but you should have the documents for today's meeting. If not, I'm throwing a link into the chat where you can find them. I should have done that earlier, my apologies. So if you don't have the documents for today's meeting, you can find them on the doc vault and get that information from there. So again, thanks Jenny and Ton and Michelle and Jason for your presentations. It's always exciting to see the work of the WPCC, the quality improvement that's occurred over the last year, taking into it a lot of the principles that are discussed in the WPCC and putting them to action to benefit your organization. So that's really exciting. Okay, let's move on. Let me see if I can get, because I'm going to drop some things in the chat eventually. So I need to make sure I have my document ready to go. Okay. On to North Central ACH and WPCC updates. This is where I repurposed John's slides. So if you're in the TCDI meeting, you would have seen these. If you're interested in a little more in-depth about the future of the WPCC for 2022, feel free to check out the Governing Board Retreat YouTube video. There's a link there. You'll get it in your slides and the link to the full board packet. So when you get your slides, you should be able to have that. It's also on our website, ncach.org, and you can get that information. Something I wanted to share with you that was shared with the board is comparing the old mission of the ACH to the new mission of the ACH. And this will help explain some of the transition as you see us as we're shifting our focus and our priorities. I'll let you read it. I don't need to read to you, but you can see that shifting in focus really to that whole person health and health equity, which we have really talked about here in the Whole Person Care Collaborative, of really looking at the whole body and looking at everything holistically. And what we've been talking about more recently was unifying the stakeholders, supporting collaboration and driving systemic change, and doing some multi-sector collaboration. So you'll see that as we shifted from the old mission, which was under the MTP, and it was really clinically focused, to more of whole person care. You'll see that through the MTP, this will all look familiar, that we're really divided by clinical groups, whether you're primary care we're divided by projects, and we're really focused on specific projects. Whereas now we're looking at the overall systems of care and how that will affect and drive change, realizing that what's on the left, you can't really do those independently. You really need to look at a system and drive the different components of the system itself. So we will be, what I had started to say and got my words minced, the moving from individual work groups, which is TCDI, WPCC, community-based care coordination, opioid, CHI, and tribal, to a different type of transformation where that is that system of care, moving from that project partner focus and thinking about system levels and who's at the table, who's not at the table, recognizing it's more than just one sector that needs to work on these issues. So with that, here are the 5 strategic goals of the ACH, and I'm going to drop a PDF, a link to a PDF, which has this in there, but it also has the different strategies to go with them. It's in the chat box. So we are really looking at equity, and John and Nancy Nash-Mendez, who's on our board, are participating in the Learning Equity, an Equity Learning Collaborative. Our board and staff have been going through some equity learnings together, and we'll continue through that 2022. And we're also developing some funding mechanisms for partners to continue their equity journey within their own organizations. And when I say partners, that truly is all encompassing for the ACH. We're no longer identifying partners as just one sector. Our next one is to promote coordinated whole system care. That's really the care coordination work that Caroline has been working on. She's leading an effort to strengthen partnerships and driving multi-sector collaboration. She'll be conducting a network analysis to better understand who's at the table and who are we missing. This isn't to say that we are trying to get as many people at the table at one time, but rather to be more strategic to ensure that we have the right people at the table. Not that everyone isn't important, but when that voice is missing, it really shows. The third one is improve health outcomes for people struggling for behavioral health issues. And Joey's going to continue his recovery coach work that he spoke about during the October meeting. If you missed that, feel free to do that recording. It's on the website under the WPCC meetings. And I'm looking at putting together a behavioral health stakeholders meeting. We recognize that there have been a lot of increased behavioral health issues over the last year, really exacerbated by COVID, but it also highlighted the behavioral health system and the strain that's on it. So what we want to do is put together a steering committee to design this meeting, which will include 5 to 7 individuals, to design a meeting to bring all the different sectors, stakeholders together to talk about what is going on in behavioral health. What do we currently have? Who's working on what? Because we have a lot of different little pockets. This is not just, say, the behavioral health organization, but this is law enforcement. This is the judicial, the schools, primary care, acute care, community-based organizations. I mean, it's all encompassing. When you think stakeholders, those with lived experience. So how can we come together and say, okay, what are the individual projects that people are working on independently, and how can we leverage what we're all working on and make the system, the entire system, more efficient? And how can we work together better to start doing some problem solving? Because we do very good at talking about our problems. We're not always as good at problem solving, because it can be difficult and time consuming, which those are two things that many of us don't have capacity for. The third one is policy solutions. We want to continue educating and advocating at the local, regional, and state levels for issues that affect North Central Washington. And the 5th bucket is capacity building, offering learning activities for all of our partners. So again, those are our strategic goals, and the individual strategies are in that document that I posted on in the chat. Our budget categories, we've combined everything. We have 5 buckets for our entire organization instead of a bucket for TCDI and a bucket for WPCC and opioids, and kind of just fragmenting that way. This really came out of our conversations with you guys and what was important to you, and really understanding that. So we have funding for capacity building, which are the trainings, the learning activities, whether it be webinars or workshops or those long-term learning activities that are 3-4 months, similar to the population health plan, which was drawn out over a year. We will no longer be doing year-long learning activities. We'll be shortening them up to 3-4 months at the max. The next one is organizational redesign. I'd heard from you guys about the need for internal improvement. And so we wanted to make sure we allocated funding for organizations to apply for, to continue that own internal improvement work, continuing what you've already started. Or maybe there are other things that maybe we weren't focused on, but falls within this care coordination behavioral health framework that you felt would be important and want to apply for funding. The third bucket is system redesign. This is an opportunity for sectors to come together to solve a common goal. And so how can you work together? We have a couple of different examples of things starting. One is Cooley Medical Center and Rural Health Resources up in the Grand Coulee area, coming together to look about care coordination. We have some work going over in Leavenworth area. So how can we help fund some of these cross-sector collaborations? The next one is just our operations budget. It's our staff and administrative responsibilities. And the 5th one is consultants, so we can continue having subject matter experts. We are a small staff, and we have a lot of expertise on our staff, but not always the right expertise for what our partners may need. So therefore, we have individuals on our bench that we can call for. Connie, Kathy, Tina, Roger have been on our bench for the WPCC. They will continue to be on our bench, and we'll be able to continue to call upon them. So when we've had organizations who have brought issues to Mariah or I, and maybe we're not able to help them, we've been able to bring in one of our team members to come in and help and hold a joint meeting to help facilitate those conversations. So just so you know, there's a lot of changes going on with the NCACH. Some you'll hear about, some you haven't. The change in leadership, which I spoke about with Senator Parlett retiring and John coming on as acting ED. We're also moving from CDHD as the host to an NCACH standalone agency. And with that comes a lot of change, not only the change in physical space, but new policies. As staff, we're laid off from the Chelan Douglas Health District and we're rehired by NCACH. So there's all those nuances that get changed from one organization to the next. Some of our roles and responsibilities internally are changing. And then the logistical stuff of new emails, document storage, et cetera. So a lot of different changes. So as we kind of muddle our way through some of this, you'll understand as we move forward, some of our delays, or hopefully not too many delays, but there's just a lot going on there. We're also in the process of strategic planning for our future state. We have a planning team that's made up of board members and a few staff. And we're hoping to hear from Healthcare Authority about our 6th-year extension and what that will entail. The last I heard, we'll hear end of November, beginning of December. I'm not holding my breath. We were originally told, I don't know, beginning of summer. And so here we are at the end of the year. So we'll see. My understanding is they're still waiting on CMS. The CMS had changed leadership, and with that, all of this was put on hold, and new leadership needed to be set in place before they could make any decisions. They're hopeful though, so we'll see. More to come with that, because once we learn, we'll share that with you guys. With the new funding buckets, we are creating funding criteria. This is where I say be patient with us, because we are creating the funding funding criteria. We're developing application processes for this funding. We're developing calendar events for capacity building. But all that takes time on top of the different transitions. And sometimes one thing needs to be put in place before we can work on something else, just logistically how it needs to work. And finally, for the bulk of the rest of the meeting, talking about redesigning how we convene with our partners. And we've had several conversations about this and the value of these meetings, and I'm not going down that road. I want to get really specific. John, Caroline, and I met last week about how we're going to convene partners, and we're not looking at it as WPCC partners. We're looking at, say, ACH partners. What does that look like? Are we going to bring together clinical partners, whether that be clinical partners being defined as acute and primary care? Are we doing larger convenings? Are we doing it by topic? Like, what does it mean and what is the purpose? And so we had our own ideas, but I thought I would shoot this out to you guys. So I have a fun thing I want to do to get to what these meetings will look like. So what does the future of partner meetings? In August meeting, I asked, what role would you like the NCACH to play? And you said support, facilitator, cheerleader, work on gaps that address social determinants of health, liaison, share best practices in an evidence-based work, and facilitate conversations on care coordination, which those are all great roles that we can play, and we're happy to do that. The top three and the last one don't necessarily mean the WPCC meeting or our partner meetings. The share best practices and evidence-based work is, but what are those best practices in an evidence-based work that you guys are, that would be meaningful to you? That we'll get to some of that in a little bit. But we'll continue to play those roles and play and continue to be partnered with you guys. So here, I see, I'm going to play a little game. I'm going to ask a few questions, and each question I'm going to choose 3 people, 3 organizations to answer. And I think I have everyone on here if something comes up except for our staff. If you don't see your organization on here, please let me know. But I have all the MCOs, I have 15 partners, and I have clinical partners, and I have action health partners. So if you're not on here, please let me know. And I'll have 3 people answer, but the rest of you are not off the hook. I'm going to ask you, if you're not called upon, to put your answer in the chat box. So the first one, let's see, is what is your purpose for wanting to continue this meeting? So what is your purpose for wanting to continue the meeting? And the first person who's going to tell us, oh, Catholic Charities, I'm going to give you a pass. Let me just give you guys a pass. Let's try this one again, just because you guys are new. We'll talk with the center. I see Loretta on, and Paul, either one. What is your purpose for wanting to continue this meeting?
I think that the communication that we receive, sometimes you hear things from healthcare authority prior to what we do, and keeping us in the loop of things that are statewide coming our directions is helpful. And then this meeting convening is one way for us to meet other providers that are not in our necessarily our sector or our discipline, but it connects us.
Paul, do you want to add anything?
I really appreciate the, there we go. Is there an echo? Am I echoing? No? Am I echoing?
Go ahead.
Okay. I really appreciate the integral sharing we do with each other on improvement projects, and it inspires me sometimes to keep going, reminds me of the end goal, that it's about improving. It's not about the numbers per se, but the numbers have to be there to show we're making improvement. I think I'm completely gone over the dark side now. I'm now interested in the numbers and know they're important and why they're important. And this has done that for me. And people sharing how they use the numbers to make further improvement also gives me that inspiration. So.
Great. I'm glad we brought you over to the dark side. For others, can you please chat in? I think for the sake of time, I just realized we're at 12:27. I'll have one person speak up on these questions, and the rest I'll ask you to chat in. I'm going to give it just a couple minutes. Realizing you're not alone. Yeah. See how others tackle similar issues. Great, thank you. Our next question is, what topic would you most likely like to discuss with your partners? Now, this is different from peer presentations, but these are actual discussions. If we were to come together and say, let's talk about diabetes, depression, whatever it may be, what topic would you most like to discuss with your colleagues? And I will open that up for Stephen and Tessa. I think you guys are from Confluence, my only two Confluence folks. Stephen or Tessa, would you like to unmute and answer what topic would you most like to discuss with your colleagues? And the others, please start dropping your answers in the chat.
I don't know if Tessa's on, sorry. And I was in between meetings. What was the question? Sorry.
I'm sorry. What topic would you most like to discuss with your colleagues?
Oh, what would I not like to discuss with my colleagues?
Okay, if you had to prioritize, like what are some top couple?
Oh goodness. I think top of mind for me right now, and I don't know how much this necessarily has to do with the whole person care collaborative, although it's related, is just staffing and how people are working through staffing challenges right now. It was nice to hear Tom mention earlier about the apprentice program and other efforts like that to restructure work, who's doing what and how it's getting done, especially in a population health type approach. So I would enjoy discussing that. And then maybe another one would just be how to help the patients that struggle the most and maybe need our help the most. We've had some situations pop up recently of patients that either are homeless or have other social determinants of health challenges, mostly related to home or transportation, that really struggle supporting themselves, and our system has and when I say system, I mean not just Confluence Health, but our system of care in the community has some holes in it that don't catch those folks very well. Or maybe there are hole plugs that I'm not aware of, and so we struggle to support those. So those would be two that are kind of top of mind for me.
Great. Stephen, and thanks for everyone who's posted. I'm going to go back and read the comments because this is really going to help shape our calendar for next year and how we're bringing partners together. Our next question is, this is more about what do you want to hear from each other? You indicated that sharing was valuable. What topic do you want to learn from your peers? So I'm going to drop that question in the chat. That'll help me differentiate your previous answers from the future ones. And I am going to call on Melina. Misty, what would you like to hear? These are topics you would like others to present on. I may have caught her between meetings too, multitasking.
Well, this is Jackie, and
Oh,
since
hi,
she has
Jackie.
a contractor at her house, I will speak up. So I think okay, I'm on my phone because I kept losing you on my computer. Let's see, what do I want to topic do I want to learn from others? I
Yeah,
think
like-
that pardon?
I was just saying, what kind of presentations would you like to hear from your peers?
I think that it's really valuable from our standpoint, at least mine, to hear what actually goes on behind the scenes, what they're doing, what struggles they're having. Those kind of things are really valuable for me. So then that way, when I'm helping members, we can, you know, I'm aware of what's going on behind the scenes, so I can speak to different things. Well, yes, I understand that, and you know, just that kind of information is helpful, I think.
Great. Thanks, Jackie. And for everyone else, thank you for posting in the chat. The next question, telehealth challenges. Yep, that's definitely a big one. Some of you have indicated that internal improvement needs to continue before you can engage with external partners. What area of internal improvement would you like to see as a guided learning activity? We've been doing a lot with depression and diabetes, so I'm curious, like what other type of learning activities, like other topics are you interested in? So dropping that question in the chat, and let's see who our lucky player is for this question. Coordinated care, I'm going to actually skip you, coordinated care. And Action Health Partners. I know this isn't a clinical per se, but we want to include other partners in learning activities as well. So what would you like to see? And others can drop their information in the chat.
Well, can I just say all of it? I feel like we are often in a position, I think many of us having worked in healthcare understand internal improvement and quality improvement, but the challenges that we have are often applying it more to community-based services and you know, lack of access to healthcare data, like health outcomes for the clients that we serve. So I don't know, this is a hard question for community to answer, but I think that would help us engage with what I refer to as the external clinical partners. You know, it's hard for us to show value right now. So how can we have some help with showing value?
Excellent. Okay, I'm going to continue on it. Just if you are noting this one, note that in your comments, so I make sure I attach your comment with the right question. The next question I have for you is, what would you like to hear from your MCO partners? And MCO partners, what topics could you present on? And I'm finding my wheel of fortune. Do we have a merit group on? Let me choose. I don't think so. Philly Medical. I got it. Oh, Shoshana is on. I got a meeting went back from her. Shoshana.
It's Kate. Kate with the merit group.
Oh, we'll let Shoshana off the hook. Kate, go. You go ahead. You were first on it.
Can you hear me, Wendy?
I know.
Yeah, Shoshana, we'll let you off the hook, and we'll let Kate go since she was our first person.
Okay, now
Okay,
it's been
sounds
more
good.
than 5 seconds. So can you repeat the question? I'm sorry.
The question was, what would you like to hear from your MCO partners? And for MCOs, what topics would you present on? Could you present on, excuse me. And for everyone else, just drop your answers in the chat box.
Oh, so I think, you know, with the merit group and most of the MCOs, we want people to know what benefits people have being on a managed care program through Medicaid, and also having more consistent data that we could share on both ends from providers and from MCOs, and just trying to do what's best for the members.
Great. Thanks, Kate. Anyone else want to drop something in the chat? Sharing data and care gaps based on mutual goals. Excellent. All right, I'm going to move on. This next session, I won't call on you. So everyone who didn't get called on, you can like do sigh of relief. But here I have some topics for consideration. These are very specific topics that we are thinking about. And the answer I would like you to chat in is you're not interested in that topic. And it's okay, because maybe you're not interested because it's not your priority right now. It's not that it's not interested, so to speak. Or a webinar, you'd like a webinar on it, which is a 1 to 2 hour, think of it that way. A workshop, which is like a half day up to 2 days, depending on what the topic is. A learning activity, which is that longer term, there's deliverables, things we're going to ask you to do because it's learning in action. Or you're interested in the topic, but you're not sure which format you would prefer. So those are your answers, and I'll have those answers on the next slide. And the first one, I'll drop it in the chat, is leadership development. Go ahead and chat in your thoughts on that one. All right, slow down. The next one is health equity. All right, the next one is social determinants of health. Okay, next one is transitions of care. Like from acute to primary is really what I'm thinking. Okay, the next one is staffing, just for you, Stephen. The next one is trauma-informed care. Okay, next one is care coordination. And that's the last big topic that I have. Okay, now I'm going to go to topic specific, and the first one is depression. Okay, how about diabetes? Heart disease? I know we're at time, but bear with me just a couple more minutes. We're almost done. SUD. Bidirectional integration. Care of older adults. And I have one more after that one, and we are done. All right. And the last one is anything else. What did I not do? What did I not say? That was my last topic. If anyone wants to unmic and say anything based on what we just did, or any comments, questions. This is extremely helpful. It's easy for John, Caroline, and I to go into a corner and say, we're going to strategize and do this and bring it back to our team and talk about all of this. But if we really don't know what you guys want or what's of value to you, then we're not going to have anyone attend, and it's a lot of time and money wasted on something that's not of value. So great. I just heard a great presentation on 42 CFR, because I think you're the third person, Nicole, who put that in, or maybe you've put it in 3 times on different things, which is totally fine. But I heard a really good conversation, webinar from Healthcare Authority, and I want to see if we can bring it to our region, because I think you guys would really appreciate it. I've been looking for it since we've had a conversation last year, and I just had difficulties. But I've held you guys over for 3 additional minutes. Thank you for hanging in there with me. I appreciate your feedback, your comments. If you think of something else, feel free to email me. And all of those other changes, like email and phone number changes, I will be in touch with you guys to let you know when that does happen, so that you don't lose contact with us. You can't get rid of us. We're here to stay. So with that, here are some staff transitions, just so you kind of know what we're doing. I told you earlier we were transitioning. We have the new communications manager. We are hiring a new data director. It's in your slide deck. You can read it later. Our next meeting is December 6th, and I will see you all there. Thank you all for your participation today. I really appreciate it. Have a good day.